Next, we'll evaluate biological markers, an essential element when one is trying to practice truly patient-centric cardiovascular prevention. Here you see a slide that I've used for some time actually, and it's one of my favorite slides. It's a slide of a bicycle because the frame of the bicycle represents the non-modifiable risk factors: gender, genetics, and age. Whereas the spokes of the wheels represent modifiable risk factors, those risk factors that we can actually do something about. And the reason this is important is that, look, we can't do anything about the frame of the bicycle, but we can clip each of these spokes because cardiovascular disease really is a multifactorial disease. And in order to do some significant damage to the prospect of your patient developing a heart attack, stroke, or death, to nullify that possibility, we have to go after each one of these cardiovascular risks. And here you see what they are. Well, we all know about hypertension, hypercholesterolemia, but there are other ones as well. Things like low omega-3 levels, or just like we discussed a moment ago, LPPLA2, lipoprotein-associated phospholipase A2. But what we have to do really is be able to determine whether or not these are just biomarkers, or are they risk markers or even risk factors. Risk factors being the most significant of the three, those that have a clear causal relationship, and those factors whereby when we actually diminish them, they will result in a reduction of cardiovascular events. And that's a very important distinction, and one which we will now discuss. So the American Heart Association has a very tight framework to establish risk markers of cardiovascular risk. So this will elevate the biomarker to the risk marker. And there are 6 elements here, and they are proof of concept, prospective validation, incremental value, clinical utility, clinical outcomes, and cost effectiveness. And it's interesting that cost effectiveness is actually included in this scheme. And so when we evaluate something like LPPLA2, for instance, we need to go through each of these steps from an American Heart Association standpoint in order to determine whether or not it meets the criteria in order to become a true risk marker. When we look at lipoprotein-associated phospholipase A2, it is clearly a biomarker for rupture-prone plaque. LPPLA2 is a vascular-specific inflammatory marker, and it is absolutely critical in the formation of rupture-prone plaque. And as we all know, rupture-prone plaque is the main culprit in causing a heart attack. So when one experiences a heart attack, one has a plaque which fissures, ruptures, and then a clot forms, and LPPLA2 is an integral part of that process. LPPLA2 is actually FDA cleared, and it's a commercially available blood test, and frankly, it's the only blood test available and approved for predicting both heart attack and stroke. It's known as the plaque test, or PLAC test. The next slide is a forest plot demonstrating the impact that LPPLA2 has with regard to cardiovascular disease risk. And here you can see that overall, elevated LPPLA2 levels will double cardiovascular disease risk, and that's based upon a multitude of clinical trials. So based upon what I just showed you, and frankly there are other trials as well that meet the AHA criteria, LPPLA2 is in fact a risk marker. But then the question becomes, yes, it's a risk marker, but is it a true risk factor? And there's another set of criteria that we need to look at as well, and those are Hill's criteria. And Hill's criteria really emphasize causation, because once you prove causation, and once you prove also that lowering the particular biological marker that we're evaluating to become a risk factor, well, then you've proved that it is in fact a risk factor. There are 7 different criteria under Hill's system. So perhaps the best study demonstrating that LPPLA2 is a risk factor, a true risk factor, is the lipid study. And in the lipid study, we found that a reduction in Lp-PLA2 activity during the first year was a highly significant predictor of CHD events and was independent of changes in LDL cholesterol. It also accounted for over half of the benefit of pravastatin in this lipid study. So we can see the dramatic impact that diminishing Lp-PLA2 activity had on events. And if you look at the top part of the slide, you can see that when Lp-PLA2 activity was dropped over 46.6 points, there was a 35% reduction in these events, which is highly significant.